Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Rational Wellness Podcasters, thank you so much for joining me again today. For those of you who enjoy listening to the Rational Wellness Podcast, please go to Apple Podcasts and give us a ratings and review, or wherever you listen to your podcast. Also, if you would like to see a video version, please go to my YouTube page, Weitz Chiro. And if you go to my website, drweitz.com, you can find detailed show notes and a complete transcript. Our topic for today is natural approaches to preventing and managing cardiovascular disease with integrative cardiologist Dr. Howard Elkin. Heart disease continues to be the number one cause of death in the U.S. and around the world. So this is an incredibly important topic. However, despite many improved treatments, especially heroic life-saving procedures, we often fail to identify ahead of time who is going to have a heart attack. More than 50% of heart attack patients have normal cholesterol based on a standard lipid profile. But deaths from heart attacks are potentially preventable. For this discussion, we are going to try to split our time between coronary artery disease and arrhythmia. And I know it's going to be difficult because coronary artery disease could probably take up 3 hours, but we're going to see what we can do. Coronary artery disease is all about cholesterol and lipids and the prevention of heart attacks and strokes. For the rest of the discussion, we are going to talk about arrhythmia, which is a condition not often discussed, especially in functional medicine quarters. And arrhythmia refers to problems with the rhythm of your heart. That occurs when the electrical impulses that coordinate your heartbeats don't work properly. This results in the heart either beating too fast, too slow, or irregularly. There are a number of forms of arrhythmia. As with arterial disease, we will focus on a functional medicine natural approach to arrhythmia. Dr. Howard Elkin is an integrative cardiologist with offices in Whittier and Santa Monica, California, and he's been in practice since 1986. While Dr. Elkin does utilize medications and he performs angioplasty and stent placement and other surgical procedures, his focus in his practice is employing natural strategies for helping patients, including recommendations for exercise, diet, and lifestyle changes to improve their condition. He also utilizes non-invasive procedures like external enhanced counterpulsation as a non-invasive alternative to angioplasty and bypass surgery for the treatment of heart disease. Dr. Elkin has written a book, From Both Sides of the Table, When Doctor Becomes Patient, that will soon be published. Dr. Elkin, thank you so much for joining me today.
Thanks. I'm delighted to be here, Dr. Weitz.
Excellent. So let's start by having you explain, what do we mean by coronary artery disease, and why are so many patients still ending up with heart attacks?
Well, here's the thing. Coronary artery disease, there's still about close to a million heart attacks in this country every year. And I believe every 39 seconds, there's a person that dies of heart disease. So it's really prevalent. It's still our number one, it's kind of like our number one killer, both men and women. So it's very common. It's a disease of excess, okay? So we're talking about excess blood pressure, excess cholesterol, excess sugar, excess stress, excess smoking. It's really a disease of excess. And however, there's a lack of one thing, and that's exercise.
Right. So can you explain why would cholesterol, which is fat in the body, why does it start to build up in the walls of the arteries?
It's really funny. This whole cholesterol heart hypothesis started way back in the, which has been for several years now, in the 50s. And in the 60s and 70s, there were studies that were going on saying that, okay, well, cholesterol and saturated fat are really the culprit when it comes to causing heart disease. And it's not that simple. We've learned more other things in the last few years. So,
well, I just wanted to also add in here, when I ask why would cholesterol build up, I just want to make sure everybody has in their minds the fact that our body is basically designed, for us to work properly, to protect us. It's a normal part of the life cycle for us to eat animals. We've been doing it for thousands of years. Animals are going to contain fat. There's going to be cholesterol, saturated fat. So why is it that what's going wrong that the cholesterol is starting to build up in the arteries?
It's this one term called inflammation. And when I was a fellow studying cardiology several years back, we didn't know anything about inflammation. We didn't know anything about endothelial injury. We just thought that there was a blockage in the artery that got worse and worse. It was probably related to cholesterol. And around that time, when I was finishing my fellowship, the first statin came out. So that was what we thought. But
by the way, for those who don't know, you mentioned endothelial, and that's related to the arteries. The inside of the arteries is the endothelium, and the statin is a medication used to lower cholesterol.
Correct. That's okay. Correct. Thank you. So, let's face it, cholesterol is essential for life. We wouldn't be here if it wasn't. It does everything from help with absorption of fat-soluble vitamins, vitamin D, sex hormones, bile acids, myelin sheaths in the brain, also with new nerve cell formation. It's essential. We cannot live without it. But it got a bad rap because of this whole thing, this assumption that it really caused coronary disease. Now, a couple of things you need to know, what I want to, as far as the audience is concerned, we now know that cholesterol in our diet does not equate to cholesterol in the blood. So if anyone's still eating egg white omelets, it's like totally out now. So that we know that doesn't exist. Now, the whole thing about saturated fat, that's an important thing. That came out in the 60s and 70s, and these were these were studies they were short-term studies, first of all, and showed that saturated fat was associated with an increase in cholesterol. And as we learned to classify cholesterol, most specifically LDL. So think of LDL as lousy and HDL as healthy. It's not quite that simple. So what we've learned in recent years is that it's about the size of the particle. And all your audience really needs to know is that bigger is better, whether it's HDL healthy or LDL lousy. The bigger the particle size, the less likely it is to get oxidized, okay? And oxidation is what leads to inflammation, which is really the long answer to your question. Because once we have inflammation, okay, that LDL particle can burrow into the wall of the artery, and that's where we really develop coronary artery disease and also progressive coronary artery disease.
So obviously oxidation, if we're consuming lots of fruits and vegetables, those are going to contain antioxidants. But other than consuming fruits and vegetables, what other factors result in inflammation in the walls of the arteries?
It's a lot of things. First of all, the environment, air pollution, we know that's effective. Toxins in the environment. Stress is a big one. Stress affects everything. And also eating foods.
Food sensitivities.
Inflammatory foods that aid in inflammation. I tell people all the time, sugar is our biggest villain. It's not cholesterol, it's sugar. And eating sugar and carbohydrates and grains that break down to sugar, it's like pouring gasoline over fire. And these are major culprits that lead to inflammation in our arteries and henceforth coronary artery disease and heart attacks.
And also chronic infections, right? And yes. I know you like to look at the gums.
Right.
So one of the sources of that.
I think I mentioned when we were talking earlier is that when I have a patient that's persistently demonstrating inflammation, just a systemic symptom of inflammation, which is a simple lab test, I have to ask why.
Which is high sensitivity CRP.
Right. And let's say it's 3 and 4, it remains that way for like several months. Then I say, we have to look further. Okay, what's happening? And one of the major causes of inflammation is the oral cavity, okay, periodontal disease. And a lot of people say, oh, well, I went to my dentist, he says everything's fine. But not every dentist really knows how to evaluate periodontal disease. You often have to go, I send people to periodontists all the time because a pocket of 4 is like not good. It's not okay. And that's a nidus of infection and inflammation based on that infection. And the other one is the gut. That's probably the second most common cause. That's very important. And also uncorrected sleep apnea. These are all things that lead to systemic inflammation. And whether it's heart disease, cancer, autoimmune disorders, or Alzheimer's, all 4 of those big causes, those pillars of aging have to do with inflammation. It's like the common denominator.
Yes. And I think the average person out there, when they have when they're worried about heart disease, they're thinking, okay, I just need to go to a cardiologist and I need to get put on some medications. But if you really utilize the full functional medicine model, that's really the only way you can start to consider some of these underlying causes rather than, okay, you have high cholesterol, you have high blood pressure, take this medication, end of story. You're talking about looking at the underlying factors that create the inflammation. And it is possible, but you need to cast a wider net. You need to consider P. gingivalis infection in the mouth, gut dysbiosis, food sensitivities, toxins, heavy metals, all these things are possibilities. When you clear some of those underlying causes of inflammation, that can cause the underlying reason why you have cholesterol buildup in the first place. And that's truly getting to the root cause. And it's one of the reasons why I think the functional medicine model, it can be so effective for heart disease prevention.
Right. You're absolutely right. And the model that we use, functional medicine, is really the only way, because if you go to traditional medicine, and in my case, traditional cardiology, you have high cholesterol, they're probably going to give you a statin. Okay, or they're going to probably tell you to maybe take an aspirin, or if you have high blood pressure, they're not going to wait and see whether you can get it down on your own. They're going to put you on a blood pressure medication. So we're masking things by giving people medications. Not that there's not a role for medications, there is, but it's like we jump to medications. I have a patient yesterday who came to me. She was a registered nurse, and she's telling me, she's showing me that her blood pressure's bad. I said, it looks like you will probably need medication, but let's not jump to that right now. It's not so high that we need to worry about it. So let's track it. Let's go on a couple of supplements. Let's work on lifestyle, and we'll reevaluate. The average doctor, cardiologist, would not do that.
Right, absolutely. By the way, you mentioned aspirin. I guess the recommendations for aspirin have been taken back a bit, huh?
Yes, thank goodness. I think with I really never believed that everybody over 50 should be on aspirin, but for years it was given as primary prevention. So let me just segue for a minute. So primary prevention is to prevent a heart attack or a stroke in someone who has no known coronary disease whatsoever. Okay, but now secondary prevention, someone that's had a heart attack or a stroke, they've had a stent, they've had bypass. This is a higher risk population, and we still think that these patients should be on aspirin for the duration of their life. But the study that came out, whose name I can't remember right now, it came out actually about a year or so ago, that it's overkill, and actually there's more bleeding from aspirin than saving heart attacks and strokes. So that was changed.
Right. So essentially, the reason why aspirin was being given was because aspirin and all non-steroidal anti-inflammatories tend to thin the blood out a little bit. And so if the blood is a little thinner, less likely to clot and form strokes, lead to form clots, lead to strokes and heart attacks. And what they found was that while it thins the blood out, the risk of having a bleed somewheres counteracts the potential risk of a clot. Unless you really know the person's at higher risk of a clot, it's not worth it.
Right, so right. And I should mention, just understand this thing about a blood clot. So you have a plaque in the coronary artery, and it could be there for years, and it often is there for years. We still don't know in 2020, what makes a stable plaque become an unstable plaque? We don't know that.
Okay, can you explain what a stable plaque is?
Okay, stable plaque is just mostly it's going to be more. It's a cholesterol smooth muscle plaque, but the composition it has more fibrous tissue in it, more scar tissue in it. So the lipid pool, the fat pool, is actually less. And these can stay. And there's no way to look at an artery and tell that from a scan. But we know by looking at them at autopsy and so forth, it's a stable plaque. Unstable plaque has a larger lipid or fat pool and thinner margins, so thinner fibrous tissue. And those can rupture at any time without warning. And once that plaque ruptures, and it could be a 40% blockage, once that plaque ruptures, then a blood clot forms. And that's where aspirin can help. So it's a plaque rupture that leads to a blood clot or a thrombosis. Then you have a heart attack or a stroke, depending on the location.
Right. So let's say, so you have this plaque that's blocking, say, 20, 30% of the artery. And it becomes, it can lead to a heart attack if either A, it blocks the entire artery, continues to grow and grow, or a piece of it breaks off. And that's what we mean by this unstable plaque. And then you get this inflammatory reaction and you get this clot formation and that then blocks the artery, right?
Right. And you remember there's still almost 1 million heart attacks a year in this country. That's a lot. And
right.
Probably 50% of these people have normal cholesterol levels.
Right. And so a lot of doctors are having patients get a test called a coronary artery scan. And that's to look for these plaques. But what does that really show?
It's a good test. I use it a lot. It helps me to prepare my patients for their treatment protocol. I'll tell you how. So you get this test done, and it tells you the degree of calcium in the artery. There's 3 major arteries. It tells you the degree of calcium.
3 major arteries that go to the heart.
Yes. So you get what's called a coronary artery calcium score. A perfect score is 0. You don't want to have any calcium in your arteries, but it's unlikely as you get older. And then what happens, like if you go, I happen to like Harvard, UCLA, they have a very large database, and they have a wonderful doctor who's been researching this scan for over 25 years. Anyway, so they have a database of 30,000 patients who they say, okay, this is how you compare to other 60-year-old males. You're in the 30th percentile. Not too bad. You're in the 40th, 50th. Well, that's a little worrisome. You're in the 80th, 90th. That's high risk. So it does help stratify your risk, but it doesn't tell you who has a stable plaque or an unstable plaque.
It also doesn't tell you, it only shows calcified plaque, right? Not soft plaque.
And really, if you look at a plaque, if you could microscopically, about 1/3 is calcium, and the 2/3 is like soft tissue that you do not detect with that scan.
Right. So you get a coronary calcium scan. It can be helpful if you have a calcified plaque. But even if you have a score of 0, it does not mean you don't have any plaque. It just means,
I was one of those people.
Okay, exactly. It just means you don't have any calcified plaque.
Right.
And non-calcified plaque tends to be less stable, right?
Right.
And by less stable means that it might break off, in which case it could form a blockage.
Right. The end result is always going to be a thrombosis or a blood clot, and that's where the aspirin does come in. But that's what it's really based on knowing the calcified plaque actually could be considered protective, because it's less likely to rupture. But
now, is there a way to test if you have a calcified plaque or not?
Well, calcified plaque is very well done with the coronary calcium scan.
Right.
The question is, how can we detect
unstable plaque?
So I've been studying, I told you there's a new laboratory test. It's relatively new. It's not been used much in this country. It's called a PULS, pulse. And it started off, I forgot what it stands for, but it started off in Canada. Now it's being adopted in the United States. And what they've done, they've set a number, over 100 biomarkers to detect an unstable plaque. And they They tested 3 different centers, and they all came down with 9 biomarkers. I'll explain that in a minute. And then taking those biomarkers into consideration, if you take someone's a blood sample, it can give you a score. So the higher the score, the worse off you are. So you want to have a score less than 10. And although it's new thinking and it's a new test, what a great novel idea, because it can take someone who's got risk factors, who's totally asymptomatic, but who has a high score. That means there's endothelial damage in that vessel, and there's ongoing inflammation that we cannot see, and that can presage a heart attack. So it's very exciting to be able to do this, and I think you'll be getting more of this in the next couple of years. It's a simple blood test.
So therefore, once you find a patient who has an unstable plaque, this is a person you need to really focus on and be very aggressive with treatment.
Right. This is when what we do in functional medicine really makes a difference.
Right.
Yeah. I mean, it's more than a statin. It's more than a beta blocker or an aspirin. It's lifestyle.
Right.
And that's what we do.
Now, when you go to your standard, get your standard physical exam from your primary care doctor, they do what's called a lipid profile as part of the blood screen, if you're lucky. Because the insurance companies are so strict these days, they hardly want to cover any lab testing. And it's only gotten worse and worse over time. So if they do this standard lipid profile, it looks at total cholesterol, it looks at estimated LDL, it looks at HDL and triglycerides. Right. But that's not really an adequate way to screen for heart disease, is it, Dr. Elkin?
Not at all. But I will tell you that most cardiologists do that simple lipid profile that you can get from a family practice, a general internist. It just tells you what's normal and what's abnormal, but it doesn't tell you anything else. Because once I get an LDL, let's say it's 110, which is barely above normal, okay, so doesn't tell you what's going on. And so I want to know more so we can order what you and I know about is called advanced cardiac testing or advanced lipid testing. That tells us about the particle number and even more helpful, the particle size. Remember, I already said bigger is better. You won't know that unless you do a more advanced test.
Why is it that the average cardiologist is not taking advantage of this available blood testing?
I think, to be perfectly frank with you, I think it's a lack of time and effort, because the way medicine is practiced today, it's so robotic. It's like, oh, you have this, you on a statin. You have this, you go. That's why I'm practicing my own, because I can do the type of medicine that appeals to me, that I think really helps people and saves lives. I think doctors are burnt out, standard medical doctors, and I think they said that they still have, in all the surveys I've read, the major one complaint that patients have about the doctors, they do not feel heard. And they say, oh, you got one foot on the door, one foot out the door, or they're sitting there typing while the patient's, I don't bring my laptop in the room with me. I can't do that. I can't focus on the patient. So it's time intensive. I have to do a lot of education. And I have a nutritionist that's in my office 2 days a week that does a lot of, she helps a lot. But when it comes to lipids, I'm the guy, and lifestyle, because, I have to walk my talk.
Yeah, so essentially what you're saying is unfortunately, and I'm not sure if all the patients are aware of this, but the healthcare system today is essentially controlled by the insurance companies, and doctors, unfortunately, do not get reimbursed by insurance companies for the amount of time they spend.
Right.
And so therefore, based on the way the insurance controls things and the reimbursement, and medical doctors, primary care doctors, and cardiologists are basically limited to a 5 or 10 minute office visit. And unfortunately, you can't go into having time to explain this kind of detailed testing and lifestyle recommendations and diet in a 5 or 10 minute office visit.
You really can. And let's just take whether it's Cleveland Heart Lab or Boston Heart Lab, and they're both very good when it comes to specialty.
So those are examples of advanced lipid profiles.
But when I get the test packet, after first go over the lipid values, then I'm to say, okay, this is your inflammatory profile. You have inflammation. This is your metabolic profile. You've got diabetes or pre-diabetes, or you're at risk of diabetes. There's so much to explain. You cannot do it in 5 or 10 minutes.
Right. And so these advanced lipid profiles, they vary, but typically besides the things you mentioned, like LDL particle number and particle size, they also look at the size of the HDL. They also look at a particle known as Lp little a. They look at homocysteine. They look at some of the inflammatory factors like high sensitivity CRP. They look at whether the LDL is oxidized.
Yes. Really useful information.
I've really been enjoying this discussion, but now I'd like to pause to tell you about the sponsor for this episode of the Rational Wellness Podcast. This episode is sponsored by Pure Encapsulations, which is one of the few lines of professional nutritional supplements that I use in my office. Pure Encapsulations manufactures a complete line of hypoallergenic, research-based dietary supplements. Pure products are meticulously formulated using pure, scientifically tested and validated ingredients. They are free from magnesium stearate, gluten, GMOs, hydrogenated fats, artificial colors, sweeteners, and preservatives. Among other things, one of the great things about Pure Encapsulations is not just the quality products, but the fact that they often provide a range of different dosages and sizes, which makes it easy to find the right product for the right patient, especially since we do a lot of testing and we figure out exactly what the patients need. So, for example, with DHEA, they offer 5, 10, and 25 milligram dosages in both 60 and 180 capsules per bottle size, which is extremely convenient. And now, back to our discussion. So let's go over some of the particular things that are found on an advanced lipid profile and some of the recommendations we can make from a natural approach for helping these patients. So let's say we have a patient with an elevated LDL particle number and or an increase in small dense LDL.
Okay, so small dense particles, remember, bigger is better. So if you have a small dense particle size versus a large buoyant, it's actually not in your favor because it's about 30% more likely to get oxidized, which we know leads to inflammation and plaque. So what can we do? First of all,
what type of diet to start with is beneficial for these patients?
Definitely a lower carbohydrate diet. That definitely does better when it comes to if you want to decrease the size. If you want to increase the size of the LDL particle.
Now, why are you mentioning carbohydrates? Most cardiologists would say, hey, you got to lower the fat.
Right. But I know it goes against what everybody's been taught. Right. I mean, if you look at the 90s, everything was, low fat and high carbs. And what happened? The country got fatter and we have more diabetes than ever before. So, but definitely I put them on a low carb diet. And you have to explain to them because a lot of their standard cardiologists are still telling them to go low fat. Why? I don't know. When we have science that tells otherwise. Then I do use niacin, which is actually a vitamin B3. I'm using it in a larger dose than I would if I was giving it vitamin, but niacin can do what statins can't. Statins are very good at one thing, lowering your LDL. Okay, but it will not make a small particle into a large. It won't affect triglycerides. It won't affect HDL. It won't affect LP little a. Whereas niacin has the potential to do all those things. It's pretty well tolerated, and guess what? It's been around a lot longer than statins have. So, and it's a supplement. So I do use that quite a lot in my practice.
I will say that if you ask the average standard primary care doctor, they will tell you that niacin, that the studies show that niacin doesn't work.
It's based on one crummy study that really wasn't well. I mean, it was a flawed study about just a few years ago. I know. Yeah,
there were a couple of studies and they were both terrible. One of them actually didn't use niacin. It used niacin in combination with a drug that prevented the flushing. And there's
Right.
all sorts of
Sure.
side effects that come with that drug. And they reported the study as being a study on niacin.
And here's another problem that a little off the record here is that, see, when you're in medical school, you go through your training, you are taught how to evaluate studies. We learn about statistics. We learn about meta-analysis, Bayesian analysis, all that stuff. But when you're in practice, like, you forget all that stuff. There's no time to think. So this drug rep comes and tells you what this is, and you just buy it. That's another thing about the current medical system that really gets to me. But niacin can be very useful. I've been using it for years, and it does things that statins don't.
What about using red yeast rice?
Red yeast rice is also, so actually, if you look at the original statin that came out when I was a fellow in the early mid 80s, it was red yeast rice, which actually is a supplement that came from a plant in China, and I've used it, and there's certain patients that refuse to take a statin, just refuse. And I don't try to fight it, even if they have coronary disease. I always believe in patient smarts and what they feel comfortable doing. But I've had some success with red yeast rice supplement, and I believe Dr. Mark Houston uses a much larger dose, and he's had success. So, but I have found it to be useful.
And adding tocotrienols.
So tocotrienols it's like a form of vitamin E. It's got tocopherols and tocotrienols, and there's various subclasses with each, but the tocotrienols are an interesting class, which actually can actually lower cholesterol and do it quite nicely. So that's another thing. Another thing that can be helpful is bergamot. Bergamot is a supplement that you can get, and actually works two ways. It works by decreasing cholesterol production by the liver, and also by decreasing cholesterol absorption in the gut, which is kind of unusual. But I've had some success with that. Is it as good as a statin? No, probably not. But I mean, it depends on what I'm after. And I listen to what the patient's preferences are.
And so besides statins, what other medications are there for lowering LDL levels?
Well, let's see. We talked about red yeast rice. We talked about niacin. We talked about bergamot. There's also berberine. Now, berberine is another herb we use a lot. We use it for functional gut disease. Also, we use it in diabetes and prediabetes. But it also has an interesting effect. And I don't want to go into all this detail, but there's this new class of drugs that are very expensive that you take twice a month subcutaneously called a PCSK9 inhibitor. And I don't mean to bore the audience here, but there's a receptors, PCSK9 receptors in the liver. We know that that's where cholesterol is produced. And so, but basically, berberine is a natural PCSK9 inhibitor. So again, these supplements can be very additive. I don't necessarily think that one would do the entire trick, but it depends on what you're after and how low do you have to lower cholesterol anyway, unless you are high risk.
Right. By the way, one of the reasons why sugar and carbohydrates are such a problem is when you look at the mechanism by which these drugs work, like statins and PCSK9 inhibitors, they're not binding with cholesterol and taking it out of the system. They're reducing the body's production of cholesterol. That's right. Most of the cholesterol that's in the bloodstream is being produced by the liver. And the liver makes cholesterol from glucose. And so that's how the statins and these other drugs work. Now there's a new cholesterol lowering medication that works by a different mechanism.
Yeah, I forgot the name of it. It was just approved by
pempedoic acid.
Right. It just was approved by the FDA, I think, a couple of weeks ago. And it's not a statin. I think it does work in the liver. It's a different, I don't know where in the chain of events, but it will have a modest effect on decreasing LDL cholesterol. I think if you look at statins can decrease it 30% or more. And then the Zetia, which works on decreasing cholesterol absorption in the gut, maybe 10%. This is like in between, like 20, 25%. So it's another tool to use are certain people that are statin intolerant or who won't take statins. But again, I would probably want to use this more in my higher risk patients versus just anyone with an elevated cholesterol level. but I'm sure it will be misused, like most of these drugs.
So now let's say we have a patient who's has low HDL. Now HDL is the potentially protective lipid that HDL, if it's effective, if it's functional, will produce reverse cholesterol transport, meaning it takes the bad cholesterol, the LDL, out of the system.
Correct.
And so ideally you want to have a higher HDL level.
Right. So when do we see low HDL? I'm talking levels like 20, 30, really low levels. First of all, it tends to be genetic. I've done enough family studies in my career to see that. It tends to be low with obese individuals. So weight loss can be important in actually improving the HDL. Low thyroid is one other condition. You always want to check the thyroid status. Smoking is known to be a factor in decreasing HDL. But again, there's also a genetic component. Also, there's a metabolic situation. If you look at your diabetics, your pre-diabetics, or your metabolic syndromes, they tend to have kind of like low HDL, high triglycerides, and moderate LDL. So there's a pattern we look for. They tend to have a very low HDLs as well. Now, so what do you do about it?
And then we have bodybuilders on steroids who often have very low HDL.
I have seen in my practice women, physique competitors that take low dose, the so-called safe steroids. I don't know what safe means anymore, and I've seen single digit HDLs. Really scary. Not like levels of 8, 9.
Wow.
Very scary. Yeah. So yes, certain drugs can certainly cause that.
So how do we elevate the HDL?
Okay. Weight loss, smoking cessation. You have to just quit. No, it's not, and exercise. Probably more cardio, aerobic activity. So that's going to be important. So a lot of lifestyle can improve your HDL. And I have seen them go up like 10, 15 points, people that really employ those methods. Now, I will tell you that over the last 25 years, there's been at least 3 different trials based on different medications that we thought would improve HDL or augment it. And what happened, all these trials were halted midway because they actually found more deaths from those taking this medication. That was before we knew about particle size and functionality. Like we have learned that some HDL is functional and some isn't. And it's more than about what the number is. And so we don't know.
There are patients who have very high HDL that tends to be non-functional, right?
Right. Exactly.
Like they have HDL of 90, 100, or
it's got great, right? But it's not necessarily good at all. So drugs have not been helpful in that regard. Now, diet is very interesting. So although saturated fat has been maligned or vilified like beyond belief, saturated fat has a few advantages. It can actually increase your HDL level. It can also increase, it can actually decrease Lp(a), which we haven't really talked about, and can also increase the size of the LDL particle, which is really interesting. So even though it's been maligned, it does have some potential benefits when it comes to this cholesterol thing.
Yeah, I've used coconut oil with some patients and seen a rise in the HDL. What about fish oil for improving HDL?
I haven't seen it do, but fish oil, basically anybody over the age of 40 is going to benefit. I use it. It's my right-hand supplement.
Very cardioprotective, reduces inflammation.
It can also help with blood thinning and in a protective way, as opposed to causing bleeding that you would get from aspirin. So, and it also can help prevent, but we talk about arrhythmias in a minute, it can prevent sudden death. It's been shown to be useful there. So as far as HDL, it may have an additive effect. I don't think
niacin can help somewhat with HDL, right?
Definitely I've had niacin. I've had people increase it like 15 points with taking niacin. It tends to be dose dependent, meaning the longer dose that they can tolerate. And I usually go up to like max 2 grams a day. I don't feel comfortable going beyond that.
Yeah. Yeah, I think there's some other nutraceuticals like lycopene, some other.
Yes. I'm kind of basic. I stick to the ones that I know work. that I've had a good experience with. But I'm always open to new ideas and suggestions.
Right. Another factor on advanced lipid tests is homocysteine, which is another protein found in the blood that increases the risk of heart disease.
Right. So homocysteine, this is really a big thing now. It's really an amino acid, and your body normally wants to break it down to something called methionine and cysteine, but some of us aren't able to do that. And so the homocysteine levels build up in the arteries, and they could also cause plaque of the arteries, both in the heart and in the brain. So it's not a good thing. And now that we've done a lot of genetic testing, which you're not necessarily going to talk about now, there tends to be a propensity of people that have this thing called MTHFR. They have a variant. It's a SNP, which is basically a typo in your genetic makeup. But these people, and I'm one of them, but although my gene's not being expressed, but 60% of us have this, and that can lead to high homocysteine levels. So it's easy to decrease homocysteine levels. And I have my own kind of product to put together, and it's B vitamins, but it's a higher dose B vitamins you would expect. So it's always worth to try that because, again, if you're high risk, you want to be able to decrease that risk easily, and you don't need a medication. It's simply a combination of B vitamins.
Yeah, one other nutrient is trimethylglycine that also can be very effective for homocysteine.
Naturally, I include that in my supplement, so that's great.
So what about LP little a? Now, LP little a is the particle that the trainer, Bob Harper, from The Biggest Loser, who had a massive heart attack, he had an otherwise great cholesterol profile, except he had an elevated LP little a.
You know, LP little a is the biggest bugaboo I know, and it's part of an advanced lipid profile, so you're going to get the value. And my younger patients that have heart attacks, and I have quite a few, invariably you're going to see, oftentimes I should say, at least elevated LP little a. So it's a fragment of LP. It's a fragment of LDL. It's very sticky, very inflammatory, and it's like not a good thing to have. And unfortunately, diet and exercise won't touch it. So it's it doesn't have much role there other than perhaps saturated fat may help. And there's really there's no medication that has been really useful. Again, I've had some good success with niacin. It doesn't always work, but I've had someone drop their LP as much as 100 points with high dose niacin. So I have had success.
Great.
And there is something in the pipeline.
I think there's a drug that is in the final stages of testing or close to getting approved.
At UCSD, and we're talking like about a 70% reduction in like less than 6 weeks, which is amazing. However, it's a drug. It's going to be a biologic, which means it's going to have to be injected probably a couple times a month. So, but
probably thousands of dollars per month.
But in those that are really high risk, it could be a life-saving, part of your armamentarium. So it's a useful thing.
Right. Let's bring up one more particle, and then we'll move on to arrhythmia, is TMAO, which is very controversial. And I know that you've been starting to test it as part of the Boston Heart Lab. TMAO is another protein in the blood that was developed by Stanley Hazen from Cleveland Heart Lab that's been shown to correlate with higher rates of heart disease. But it's very controversial, and I'm kind of skeptical of this concept because when you consume foods like fish or eggs that have choline or L-carnitine or phosphatidylcholine, that increases the levels of TMAO. And we know that those foods are heart healthy, and yet we're being told that these nutrients like choline and L-carnitine, which we know are super helpful for patients with cardiovascular problems, we're being told that they're harmful.
Right. And also brain healthy for that matter.
Choline, crucial for brain health.
I look at it because I do a lot of Cleveland Heart Lab testing, and it's kind of standard. And I will tell you, most of the patients that I test don't have increased CT. I wonder whether it's overemphasized because, I see a lot more abnormalities when I do a lipid profile, but some are elevated, but I would say the majority of those that I've tested really aren't. So what do I do? Right now, I'm just observing because it's like, okay, what do I know that can help a patient's risk? Particle size, LP little a, homocysteine, working on their diet. So I totally agree with you. Choline is lacking in so many people in their diets as it is, and it's so useful. And as far as L-carnitine, that's like very important in cardiovascular health because it helps to bring nutrients to the mitochondria so energy can be produced. So I just don't see at this point, I'm not, changing people's diet and because of it. And also, is it really the food or is it because the gut isn't healthy?
Yes.
Is there a microbiome problem?
Right. Yeah. Absolutely. So that's something to continue to discuss over time. So let's move on to arrhythmia. This is a topic not often discussed, but is increasingly common, especially among us aging baby boomers. And perhaps you can tell us, what is arrhythmia?
Okay, arrhythmia is really a rhythm disturbance. Okay, so you have this thing called normal sinus rhythm or sinus rhythm, which is your standard rhythm that most of us have. If you have a disruption in that, it's an arrhythmia. So it's kind of a wastebasket term for a lot of different things. Then we break it down to what type of arrhythmia is it? Are they isolated extra beats or premature beats? Or is it something that's sustained?
Or somebody who just can't dance?
Pardon me? Yes, right. Right. It's interesting. So a very common complaint in a cardiologist's office is palpitations. Now, I, for one, have never had a palpitation, knock on wood. So I have to really delve into, I have to really ask people, what does it mean? Is it skipping? Is it fast? Is it slow? Because I can't relate. But fortunately, there's ways we can monitor patients. Now, most arrhythmias are benign. So what I'm treating are symptoms and lifestyle. But some are malignant, like ventricular tachycardia fibrillation that leads to sudden death. So part of my job is to figure out what's really important and what's not. And if it's not important, what can I do to assuage the patient's their uncomfortable feelings? Because it can really run you. Some patients are very debilitated by the presence of palpitations and arrhythmias. So there's more. What I'll talk about briefly is that what I'm seeing more and more of is atrial fibrillation, which used to be the most common arrhythmia that we saw in people over the age of 70. But I will tell you, I'm seeing younger and younger people with it now, Ben. And I have two of my closest friends had to have ablations in their early 50s because they had such refractory debility.
What's an ablation? Can you explain what that is?
So ablation is done by a cardiologist, but like me, but they specialize in electrophysiology. So they specialize really in arrhythmias and trying to study arrhythmias. And if they find something that, because medications are really suboptimal, tons of side effects that can actually make arrhythmias worse. So with an ablation, it's a procedure in which you go through the heart, you map out where the arrhythmia emanates from, and then you can zap it with either radiofrequency waves or cryotherapy, which is cold. And you can potentially cure an arrhythmia problem with ablation. So it's invasive.
Basically damaging, either burning or freezing the part of the nerve that is leading to that contraction of the heart.
It's sometimes part of the heart muscle, but you don't want to do that. But I mean, it's pretty actually, in the proper hands, the side effects are pretty low. But so those are, so AFib is I'm a solo practitioner. I probably get 3 or 4 new cases of atrial fibrillation every month in my office. I mean, it's so common. And that's probably the most significant thing because we used to think that, okay, well, it's important to treat because the heart's beating irregular, there's a propensity for blood clots to form in the heart and to break off and cause a stroke, which is devastating or could be potentially devastating. But also what we've learned in recent years, it can be a cause of heart failure, progressive heart failure. But here's the new one that we have found is that it also can lead to early dementia. Maybe there could be a little microemboli going to the brain that we don't really recognize as strokes. So it's not a good thing.
So which dietary factors are important for helping to manage a patient with arrhythmia?
That's a good point. Well, first of all, magnesium is always important. Actually, if you look at sodium, potassium, magnesium, they all are your basic minerals, and they're essential for proper nerve and muscle and nerve function. And they also sodium regulates body fluids. So you want to have. Do
you want to add salt or you want to remove salt?
I don't usually deal with removing salt unless I'm dealing with a patient with heart failure, liver failure, kidney failure. I think this whole thing about salt, we pretty much have discounted the importance of it. I know that the Heart Association is still saying low salt diet, or less than 2.5 grams a day. And if you're an active person, that's nothing. It's nothing, So I don't think salt affects your heart rhythm at all. So what affects it? Stress is a big one. I think fatigue. Another big thing is sleep apnea, uncorrected sleep apnea.
Okay.
So there are things that we have to look.
Caffeine, energy drinks.
Yeah. Energy drinks are the worst because they not only can be rhythmogenic, they can also, there's an EKG abnormality called prolonged QT interval, which doesn't mean much, but it's an EKG diagnosis. And that itself can lead to life-threatening arrhythmias and sudden death. It's been reported in young people. It's like not good things to have.
One of your articles I read said that celery, garlic, and onions can play a role. Have you heard that?
I haven't heard that. I mean, I'm a big user of magnesium and hydration in general. I also use an amino acid called taurine.
Okay.
It's useful. Magnesium tends to quiet the heart.
Right.
And it can be very important, especially people that have bothersome palpitations. Another thing in women that are going through menopause is hormone replacement therapy. I mean, it's not the only reason to go on it, but low progesterone is a very important factor in causing irregular heart rhythms, which I didn't learn. I didn't know that until I did my anti-aging medical fellowship. I didn't learn it at all in cardiology.
Right. Now, what about hawthorn extract?
Hawthorn berry is good for the heart. It's not my go-to, but it's something that's additive, and a lot of patients are taking it. They've heard about it. They see it on the internet, and they've heard the utility of it. So it can be useful for heart rhythm. Yes.
What about CoQ10?
Definitely CoQ10. Yeah, that's.
And I've also seen some articles mentioning vitamin C, and of course, vitamin C. There's actually a protocol for using vitamin C for Lp(a), right?
Yes. Yeah. So definitely, so vitamin C, magnesium for sure, taurine if it's for sure. And also looking at the lifestyle, like smoking is bad, fatigue or poor sleep habits are not good. I mean, the lifestyle today, we're living in very stressful times. I won't go into the political scene, but we all know what's happening. People are stressed. I have people that come into my office. Well, I can't say it over the air. But they say, where my blood pressure is high? Who's in the White House, right?
I hear you, Howard. But we're going to try to stay away from politics. Can maneuvers that stimulate the vagal nerve be helpful?
Okay, so it's interesting. I do this diagnostically. If someone has an arrhythmia in my office, and I'm trying to you can actually do vagal maneuvers, like it's called carotid massage.
Right.
Carotid massage will activate the vagus nerve because you've got a sinus in there. And I've had it actually break an arrhythmia. It can be very useful. So I use that. I don't use drugs per se for that because they can have some nasty side effects. But I do use it. I tell my patients if they're having what's called SVT or supraventricular tachycardia, which is very common, I say, okay, bear down.
Right.
Cough a lot.
Coughing, gag reflex.
Right. put your head in a bowl of ice water. And if you have a partner or someone, it's hard to do your own carotid massage because people are either turning to extreme. You can't be turned, you have to get on top of the carotid artery and go up and down kind of firmly. And it's not real comfortable, so the average person won't do it on their own. But if they have a partner or a friend or a bystander, they can do that.
And then what about natural procedures that reduce stress, like yoga, meditation? And I know you were involved in a study on grounding as well.
Yes. So grounding, I did a study with Dr. Sinatra. We did it mostly looking to see the effects on blood pressure. And it can really reduce blood pressure. It's really cool. But it's also anti-inflammatory. And it's also a natural blood thinner. And it also helps with sleep. So there's I love it because it's free, right? You're just using the electrons from the Earth's surface.
Yeah, you guys should consider seeing if it has a positive effect on arrhythmia. I would think it probably would.
Yes. We didn't study that per se because we were looking at one component. And blood pressure is such a big target, But these are all additive things. I think a lot is on lifestyle and hormonal and environmental. And we're living in a very toxic world, pesticides, there's formaldehyde in everything. I didn't even know that until recently. I got scared when I started seeing all the things in our household that could potentially contain formaldehyde. Can you believe that?
Wow.
Yeah, like our carpets. That's why I got rid of all carpets.
Yeah. They have those flame retarding chemicals and a lot of furniture. You got to really try to go non-toxic as much as you can. Well, there's been a great discussion, Dr. Elkin. Any final thoughts for our viewers and listeners?
Well, here's my final thought is that, I believe in patient smarts, and I tell patients, you need to become your own medical advocate. Yes, you want excellence in doctors and nurses and healthcare, but you cannot depend on your doctor, the hospital, your insurance plan, or the federal government to take care of you. So do your research, try to find functional medicine people. Even if you have a doctor that's not traditional, you can develop your own dream team because you need to look at the lifestyle factors, nutrition, all the stuff that we talked about. And that's really what I like to lead people with is that, stay in the driver's seat when it comes to your health, and that's really, that's a very important message that I always try to get across. I'm your second opinion, you're your first.
Exactly. I think that's also very important. A lot of times people will see different doctors as, is this doctor, is it better to go to a conventional doctor or should you go to an alternative doctor? And really, they both have their place, and you're suggesting for ideal health, for optimal health, it's best to have a team, and there's some great benefits to having a conventional primary care doctor, and there's all kinds of routine testing, and it's great to see them for infections and things like that. But on the other hand, it's also good to have a functional medicine doctor as part of the team to look at some of those underlying causes of some of these chronic diseases, so you can look at things from different approaches and really get to the root causes.
Well said.
So how can listeners and viewers get hold of you, Dr. Elkin?
Okay, well, if you go to my website, it's www.heartwise.com. You learn about me, and I try to put things here on a regular basis. On Facebook, it's Heartwise Fitness and Longevity Center. And on Instagram, it's Doc H. Elkin, and I always try to post things a couple times a week. So I try to keep current, and I try to inform people of what's happening. So it's kind of I like to be contribute in that matter.
Thank you, Howard.
All right. Great. Thanks, Ben. I loved it. Very good. Thanks.
Me too.